Hospital in South Africa. The objective of this webinar is to serve as an open and participatory forum where changes in provision of clinical care that occurred during the pandemic, the COVID-19 pandemic, and those lessons learned and best practices that were identified can be shared in a participatory environment. So no pressure here. So we come with clinicians from both institutions. We come with, and we will present it a little bit later, from the Clinic Hospital of Barcelona and from Mediclinic. I'll introduce myself. I'm Dr. Maria Insua. I'm a senior clinical advisor at the TB and HIV program at the CDC, the US CDC here in South Africa. So let me just do a little bit of housekeeping and inform you how this is going to work. So this webinar is of questions, and this is the intention of the webinar in a participatory way. Due to I embedded here another platform, that is the Slido platform. Please see the link of the www.slido.do and click to insert the code #COVID-19 South Africa. In this way, you will have access to all the questions sections. So the IT team had created 4 files. Here is where you can enter your questions, specifically for each of those speakers. We're doing this because if you write in the chat box in YouTube, it's going to be very difficult to keep track of the questions. In this way, having all the questions through the Slido, we'll be able to consolidate the questions in a more organized way. So please write your questions in the Slido, because if you do it in the chat, we're not going to be able to address those questions. So the IT team, what is going to do working in the background, is going to be monitoring those questions. If you find that the question that, you write your question, but if you find that the question that you want to ask is already there, please just click the thumbs up. In that way, the IT team is going to be able to monitor how many votes or thumbs up that question have, and they are going to prioritize based upon that. This is in order to give more transparency to the questions that you may want to ask. What else? It may be possible that due to the volume of questions, we don't know at this moment, but since it's in YouTube, we expect to have a high volume of questions. We have only half an hour to address those questions after the speaker's presentations. So it may be that your question is not being addressed, but we're going to do the best that we can to send those questions that has not been addressed to the speakers and get their answers through email, and then post the response to those questions in the platform. So just to remind you, please again, just to go to the Slido if you want to post a question. So I would like to share with you which is the agenda that we're considering for this afternoon. So after I finish with the introduction, we're going to have Dr. Smat that is going to talk. Every speaker is going to talk between 5 and 15 minutes. Then we're going to have Dr. Castell, Mrs. Gemma Martinez, Dr. Trija, and then after that, we'll have the Q&A section. I will introduce all the speakers in the moment that that we're going to start with the presentation or with the chat. So I think that we can start right now with Dr. Stefan Smat. So Dr. Smat is the Chief Clinical Officer of Mediclinic Southern Africa. Mediclinic is an international private healthcare service group here in South Africa. Region. And in South Africa, I think that they count with approximately 4950 hospitals with approximately 8,700 inpatient beds. So Dr. Please, the floor is yours. Welcome.
Thank you very much, Maria. Thank you for the kind introduction, and thank you very much for this opportunity to share the lessons that you have from Spain with your colleagues in South Africa. So we appreciate this collaboration. I thought just to give some background on the healthcare landscape in South Africa, then a quick bit of background on Mediclinic for those of you that are not familiar with Mediclinic, and then just a quick update on the experience within Mediclinic with COVID-19. I don't want to take up a lot of time because I do want to leave most of the program for us listening to your experience in Spain. So just from South Africa as a healthcare landscape, we have an estimated population in South Africa of 59 million people. When you compare the age distribution of South Africa to other countries, it could be seen as a younger population compared to a more first world country. South Africa is divided into 9 provinces with the biggest population density in the big cities. The private and public health systems exist in parallel. And to have access to the private health system, most citizens take out additional healthcare insurance for which they pay a monthly premium. About 16% of the population have private health insurance. That's about 9 million people of the population. I must say a big focus of the public healthcare system is on primary healthcare because we are dealing with quite a big burden of disease, of communicable diseases like HIV, TB, malaria, and then obviously there's quite a lot of trauma to deal with as well in the hospitals. Mediclinic is one of the 3 big private hospital groups in South Africa, and we probably service about 25% of the private hospital market in the country. We do have 3 hospitals in Namibia as well, a neighboring country, but as you quite rightly said, we've got 50 hospitals in South Africa, but we also do have day hospitals and some clinics. Mediclinic was started in 1983 by our founder, Dr. Edwin Herzog, and today it has expanded to an international company with 77 hospitals in 4 different countries, 50 hospitals in South Africa, 3 in Namibia, 17 in Switzerland, and 7 in the United Arab Emirates. The total number of beds in South Africa, round numbers 8,500 about, with about 12% of those beds are ICU or high care, and our number of ventilators in excess of 800. We actually have 16,000 employees, and then most of our hospitals in South Africa are focused on acute care, and we offer specialized services to the community and to the referring general practitioners. Our hospitals vary in the size from some of the big hospitals that have in excess of 400 beds to smaller hospitals that have about 30 beds, which is in the minority. I think by law, Mediclinic is not allowed to employ any of the doctors, and therefore we provide the infrastructure, nursing staff, pharmacy services, but then rely on our doctors as independent service providers to treat patients in our acute care setting. Now, I think with regards to our experience with regards to the COVID, it is a bit delayed with regards to where we are with regards to the development of the pandemic when compared to countries like Spain. We probably lag about a month to 2 months in some countries. But we started our own preparation in February of this year. We have learned quite some valuable lessons from hospitals in other countries, especially the countries where we actually have hospitals as well, like Switzerland and the UAE. The first case of COVID-19 was confirmed on the 5th of March in South Africa. And our first admission to a Mediclinic hospital was on the 10th of March in KwaZulu-Natal. Our country was placed on a quite strict lockdown on the 26th of March, which lasted until the end of April. And then at the start of May, some of the measures were relaxed. So the current statistics of how many cases we have in South Africa, we have 151,209 confirmed cases, with a daily increase in the last 24 hours of close to 7,000 new cases being reported. The number of mortalities so far in the country, totaling 2,657, a daily increase in the last 24 hours of 128. Recovered cases, 73,543, and active cases, 75,009. I think the biggest concentration of COVID-19 cases are in the 4 big provinces, being the Western Cape, the Gauteng, Eastern Cape, and KwaZulu-Natal. And the differing doubling rates per province is indicative of how they are evolving differently with regards to the pandemic. Currently, in all our hospitals, we have 517 cases admitted, of which about 210 is in ICU or high care, and about 90 of those cases are on mechanical ventilation. I think we've learned a few lessons the hard way. It's always very helpful to learn from other hospitals in a very practical setting. We do read up a lot, look at all the news articles, but it's actually very valuable to actually talk to colleagues that have actually had a real world experience and can actually share their lessons. So I think some of our biggest challenges have been keeping up with the rapidly changing regulatory environment, which the government actually imposed on very short notice, that actually impacts our ability to provide a service to our community and patients. I think one of the other challenges is actually making sure that our healthcare workers are safe and healthy and are happy to provide the service within our facilities. We have had some quite significant challenges making sure that we have adequate supply of specialized, especially ICU nurses, to look after ventilated patients. I think I'm going to stop there with regards to some of the challenges, just to say that we value this opportunity tremendously, and I would like to hand back to you, Maria. Thank you very much.
Thank you very much, Dr. Smuts, for the excellent overview of the situation in South Africa and for the ingenuity that you showcased, just identifying those challenges. So hopefully our counterparts in Spain can provide us with some valid information. So having said that, we're going to move now to Dr. Castells. Dr. Castells is the medical director of the Hospital Clinic of Barcelona, and he's a tenured professor of gastroenterology at the University of Barcelona Medical School. Welcome, Dr. Castells, and the floor is yours.
Thank you, Maria, for the introduction. Thank you very much for Dr. Smuts for the introduction of this webinar, because it allows me to have an idea of the situation. Let me share my screen with you. Just 1 second, please. Okay, I hope you are seeing the screen. Maria, can you confirm that you are seeing the screen, please?
Yes, doctor, everything is fine. Thank you.
Okay, thank you very much. First of all, good afternoon, everyone. I would like to thank the invitation to participate in this webinar, because it's a great opportunity to share our experience with you. I hope that this presentation and my colleagues' presentation will help you in some way, because I think that the problem that you are facing are exactly the same that we faced some months ago. In Spain, we have the first case at the end of February. Actually, the first COVID patient that we admitted in our hospital was in February 25th. At that moment, we were very afraid about the epidemic curve of the pandemic. We didn't know what is going to happen. We have the experience. We know the experience in Italy. That was the closer country that we have in Spain that were facing the epidemic just approximately 3-4 weeks before. And we were very afraid about our health service capacity. Indeed, I was particularly afraid about the capacity of our hospital because we didn't know how it's going to be the peak of the epidemic in Spain. Actually, since February 25th, we have admitted in our hospital about 2,500 COVID patients. Approximately 20% of them, 500, were hospitalized in critical care units. And you can see here that approximately 200 of them unfortunately died. That is a mortality rate of 8%, with a readmission rate of approximately 6%. And the total average stay of our patients hospitalized in our hospital is about 14 days, 2 weeks. That is much more than the average stay that we have for other patients that is in our hospital is approximately half of this figure, is about between 6 and 7 days. You can see here a graph that is depicting the prevalence of COVID patients that were hospitalized since the beginning of February. And you can see here that the most important hospitalization rate was about at the end of March or beginning of April. You can see here that we have approximately 600 patients hospitalized in the hospital. And in addition, we have more than 300 patients that were hospitalized at home. That is a unit, a special unit that we have in our hospital that usually we attend approximately 50 patients. But you can see here that we were attending at that moment more than 6 times more patients than usual. You can see here the total number of patients hospitalized in our hospital at the beginning of April was approximately 1,000, but you should consider that we have approximately 200 additional patients, non-COVID patients that were still hospitalized for other reasons. And just to keep in mind that the capacity of our hospital, Hospital Clinic of Barcelona, is approximately 700. We have 700 beds. That means that the capacity that we have at that moment is approximately 500 more patients than usual attended in our hospital. The second problem that we were afraid is about, as Dr. Smats mentioned, is the capacity in critical care units. In a normal situation in our hospital, we have around 100 beds in critical care unit. But you can see here that at the beginning of April, we have 120 patients, COVID patients, plus around between 30 and 40 non-COVID patients. That means that we have a figure that exceeds in 60 patients the regular number of beds that you have in critical care and so on. I'm going to try to explain how we did this, let me say, miracle to increase the capacity of our hospital, especially in critical care units. Our contingency plan, that is my presentation is going to focus on this aspect about the contingency plan that we did in our hospital in the last 3-4 months. The goal of this plan was to try to increase the number of beds, especially intensive care unit beds. We tried to decrease patient mobilization and also to reduce the exposure of our professional to the virus. And to do that, we decrease our surgical activity. We reduce approximately 80 to 85% the surgical activity during this period of time. Of course, that we maintain our surgery for emergency cases or for oncological cases. And we also reduce our activity in the outpatient clinic. Of course, the only way that we have the opportunity to increase the number of beds is reducing the elective surgery. That is a schematic of our hospital. Our hospital is a tertiary university hospital that, as I mentioned before, we have around 700 beds that are divided in 35 hospitalization units, 26 of them used for conventional hospitalization, and we have seven critical care units that are monographic. That is a characteristic of our hospital, that we have monographic units, critical care units, and you can see here the distribution of this bed. That take into account that is the picture at the end of February. Just 1 month later, the picture changed totally, and you can see here, just depicted in red, the number of COVID units that we had at that moment. And you can see here that we increased in 8 the number of units that we are using, especially the number of critical care units. You remember that we have 7. At that moment, we had 15. And how did we do this conversion? Well, we use different units that are not commonly used for hospitalization. For example, that is the dialysis unit. That is an administrative area. That is an operation theater. That is a post-surgery recovery room. That is another post-surgery hospital, we call day hospital. I'm not sure that is the proper name in English. Is a place where we're administrating some drugs, but in an outpatient regime. That is the way that we increase the number of our units in the hospital. But we didn't have enough, and we have to establish some collaboration with other hospitals around our hospital. I mean, smaller hospital, community hospital, some of them private. Our hospital is a public one. I didn't mention that before, but we established a collaboration with 4 private hospital around our center. That it was allowed because the Spanish government allows all private centers to be mobilized for being used for hospitalization, just in a similar manner as any other public center in Spain. Besides this collaboration with private hospital, we also use a hotel. We call this project Health Hotel, Hotel Salut in Catalan. That is the use of conventional hotels. This one is the one that was allocated to our center, that is placed approximately 500 meters far away from our hospital. And that we could use this hotel as a community hospital. But to this end, we have to adapt all rooms. You can see here that we were installing some oxygen in rooms, because as you know, these patients has a very high requirement of oxygen, and we have to adapt this hotel to attend this kind of patient. In this hotel, we could hospitalize up to 400 additional COVID patients. And we also were preparing this health pavilion. That is the name of this program. That is let me say, it's like a campaign hospital. That is like a military hospital that was placed in a pavilion, in a sport pavilion, that with a capacity of 250 patients. That fortunately we didn't have to use it. It was prepared, as you can see in these images, in this image, but we were not need to use at the end. We have enough with our hospital, with the private hospital collaborating with us, and with the hotel that I mentioned before. Probably, as Dr. Smat mentioned, one of the challenge that we have to face at that moment is to have enough professionals to attend all these different units. And of course, we tried to reduce, as mentioned at the beginning, to reduce the exposure to the virus. And we start using teleworking for all professionals that can use this modality of work. And we segment all clinical teams. We call twin teams, just to split the clinical teams in two parts. One of them working at the hospital, in some cases for 1 week in different turns of 12 hours, and the other team working at home as a backup, just in case of the team that was attending patients in our hospital became infected. The other thing is the other challenge is to have enough capacity to cover the new hospitalization units. We recruit the staff, and I have to mention that all physicians that were attending COVID patients at the front line were volunteers that offered to attend this patient. We didn't need to make mandatory to professionals to stay in this unit, and I have to mention, because I'm really grateful of the all professional physician and nurse of our hospital that were volunteering to attend COVID patients during this period of time. As I mentioned before, we have to change the working condition, establishing 12-hour terms. We have to reorganize some care activities, and we have to recruit additional physicians because and nurses, because we didn't have enough to attend this so large number of beds. We recruit senior medical residents that are finished, that they were finishing his or her residency training. And also researchers, I mean medical researchers that are devoted only to research, but they offer also to go back to clinical duties. And we're also using students from our med school, the nurse program, and the pharmacy that were hired as a health assistant. As a students, they couldn't be in contact with patients with virus, but they offer some support to physicians that were at the front line. Laboratory testing was a real nightmare at the beginning. We didn't have enough experience at the beginning of the pandemic. You can see here that our capacity to perform PCR was about 100 to 150 tests per day. And at the end, at the middle of the pandemic, you can see here that we are performing more than 1,000 tests per day. The total number of PCR that we did in this period was more than 60,000 tests. And we changed a little bit the policy of testing. I think that some of the emails that I received preparing this seminar or this webinar, I think that we were interested in knowing what is the testing strategy that we follow at the beginning, and it changed depending on the period. You can see here that at the beginning of the pandemic, that when we have very few cases in the hospital and the incidence at the population level was limited, we tested only patients that we suspect that has a COVID because of the symptoms, and we didn't test non-COVID patients in whom we did not suspect COVID, and we didn't test the elective patients that were admitted to the hospital. However, in the second period, when the number of patients that were attending in our hospital was very high, we were admitting at that moment approximately 100 new cases per day at the emergency room, and the incidence of the pandemic, or the incidence of the infected cases at population level was very high, then we decided not testing individuals in whom we suspected the COVID, because we accepted just clinical and radiological and laboratory criteria for considering that the case was a COVID positive individual. But on the contrary, we want to make sure that those individuals that were admitting at the hospital for other reason, they didn't have a COVID infection. That means that we turn to test those individuals in which we didn't suspect this disease, in order to make sure that they didn't have a COVID infection. And in the last period, that is in the last 2 months, then we are testing everyone in the hospital. We are testing cases that we suspect COVID because the incidence at population level decrease, but at the same time, we want to make sure that all patients that are admitted to the hospital, that at the moment I have to mention that approximately 3/4 of the patients admitted in the hospital are not COVID patients, because at that moment we are at the end of this epidemic cure, and I hope that we will not have to attend a new outbreak of the disease, but who knows what is going to happen in the next month. But at that moment, we are testing everyone that is admitted to our hospital. We also change a little bit the flow of patients admitted through the emergency room. At the beginning, when we have very few cases, we use a high isolation box that we have in our hospital. Our hospital is a referral center for emergency diseases. We had these boxes that we started when was the epidemic of Ebola some years ago, and we have a special intensive care unit devoted to infectious diseases. At the beginning, we admitted patients that are coming to the emergency room. We attended in this high isolation box, and if this individual has to be admitted, we use single rooms. Our hospital is a public one, I mentioned before, and most of our rooms are double, but we are using a room only for a single patient, because we didn't know at that moment if we can share or we can admit 2 patients infected at the same room. But just a very few days in front, we can see here that when we have many cases, we didn't use the high isolation box anymore. We have attended in the regular emergency room. We have to create a pre-admission unit, because at that moment we use conventional PCR that it lasts for 6 to 12 hours to have the result. That means that we have we need this unit to attend this patient until we could classify them as infected or not infected. And of course, we start using our double room for 2 patients in each room. I mean, 2 infected patients or 2 non-COVID patients. And at that moment, we are not using the isolation box. Fortunately, we don't need at that moment to use the pre-admission unit, because in the last 2 months, we have fast PCR tests available, and we have the result of this PCR in 1 hour. That means that we can classify this individual from the emergency room to admit this person to a COVID or non-COVID sector of our hospital. Just finishing my presentation, that is a very difficult, I want to mention in this slide, one of the challenges that we were facing at that moment is when we were afraid of the shortage of some unit, the intensive care unit, or the shortage of some resources like the ventilator, that we, at that moment, we are not sure that we will have enough resources for mechanical ventilation for everyone that need this resource. We established the ICU triage, that is a score to classify the therapeutic limit of our patient. That is the first time that in our hospital we use this score to classify patients according to their expectancy. And it was a very difficult it's very difficult task that we did at that moment, and we asked for the support of our ethical committee in order to approve this measure that you can see here, that we established a score that range between 1 and 9, depending of some characteristic that you can see here: the age, depending of the age, the patient receives a different score. The Barthel scale, that is a scale that measures the capacity, the physical capacity of a person, the number of the condition of the chronic diseases that this patient has, or also if this person has or not neoplastic disease. In addition, we considered also some clinical manifestation like shock, or if this person has social support or not. You can see here that we can establish a score that go from 0 to 35, and according to this score, we consider that if this patient is in stage 1, is candidated to all life support measure. But if patient is in stage 3, we consider that this patient was not candidate to invasive measures. Just finishing, we try to be very transparent in our policy, the measure that we're taking every moment. And from the direction of the hospital, we send a communication, just an email to the whole organization, who are more than 6,000 professionals in our hospital. Every day we send a communication explaining what is the situation, which units are open for COVID, or which are the different restrictions that we are taking in every moment. And the last slide, just to show probably the most important information that I want to share with you, is that how we try to stimulate our professional, or what was the values of our professional show us during this pandemic. And that, as I mentioned before, we are very grateful of all of them, because they demonstrate an extraordinary commitment towards our patients and the society. They work a lot. Their dedication was terrific, working 24 hours, 7 days a week. The responsibility of each category was excellent. We found, I have to mention from the direction point of view, that we observe a tremendous respect from all our colleagues, because at that moment for us was very difficult to take decision, and this respect facilitated decision making, of course. There was an extraordinary solidarity and generosity among all of them, and all of us, and we learned that we have to show a high humility, because during this period of time we make some errors. We know that we can all be wrong, and we should recognize this error, and we try to amend in the day before, the day after. I mean that this different value, I think that we should make into account when we're trying to face this terrific or terrible situation, and I hope that we will continue having this support from our professional if we have to face again this pandemic. Thank you very much for your attention.
Thank you so much, Dr. Castel, for an excellent presentation and for the overview of all the innovations that your team conducted in the hospital. And also those difficult considerations, ethical considerations, secondary to the ICU triage. So we're going to move forward with Mrs. Gemma Martinez. Gemma Martinez is the nurse director of the Hospital Clinic of Barcelona, and is also a professor at the University of Barcelona. Welcome, Mrs. Gemma.
Hello, Dr. Insua. Thank you for the introduction. I make my presentation. You see? Yes. Okay. As explained, Dr. Castells, I explained you how all of them make the operational and the strategy of the communication of all our teams. We make a lot of things during this period of the epidemiology, and for the organization, all the teams in the hospital, we have near 600 workers. We create the crisis committee, that the principal function of this committee was executive and cross-sectional in all our institution. In parallel of this committee, we create another committee more operative. The members of this committee are experts, physicians, experts nurses that work all the teams, clinical teams, clinical terms related with the epidemiology, with the care of the patients, the treatments, and another things that we must to do. Here inside, there is nursing and advanced nurses, for example, nurses of control infection, the head of nursing, the area of internal medicine and infections, and nursing expert work health of work health inside this committee. And in parallel, we have another committee with all the responsibilities in the institutions. My hospital is organized by areas of knowledge. And we make a representation in this committee of every one of these areas, because that show Dr. Castells, the hospital have during the epidemic 2 areas: the area not COVID, and the area COVID. There is in traumatology, gastroenterology, not only COVID or not COVID. And in this technical committee includes a representation of the professionals, the first line professionals. All of these committees have an objective, that the information goes vertical and horizontal, because it is more important that all the workers have the same information. The committee crisis is formed for the medical director, is the director, the Dr. Castells, that you know them, him, and nurse director, responsible of human resource and emergency department, preventive and medicine and epidemiology. Dr. Tria is with us. The communications department, because we have a lot of pressions, internals and externals of different departments of communications. The coordinator of the operations committee, and the coordinator of expansion areas that Dr. Castells said, for example, health hotel, private hospitals, etc. The operations committee, it's coordinated by Dr. Josep Maria Nicolats. It's an expert in critical care and in medicine, in internal medicine. But there is another experts, physicians and nurses that I say you after. The technical committee is formed for every one of the different responsibilities of all the areas in the institute, in the hospital. It's more important because we have we take a very quickly decisions, and it's more important the velocity, the quickly of to make all the things that we must make in different space of the hospital, and with a lot of professionals. The professionals change more skills of them, because we make an adaptation on time, online, in every moment. Okay, and you have these members in this committee. I want to make those two professionals very important in this crisis. One of them is this personnel, the general coordinators on duty. In every hours, for example, at night, we have one coordinator in every site of the hospital for coordinate all the things that can be make in, and it's the referent of all the professionals in every hour of the day. It's more important to have a reference of everyone, and our nursing, who is the representative of all the professionals in the hospital. Every day, that says Dr. Castells, we make a committee the crisis committee make a mail for all the workers, and the nurse director make with that another with all the specification orders of affected this collective. The nurse director not only is the director of nurses, include it's inside in my direction physio trainers and social workers, social educators, and other professionals that work with the nurses and physicians medical teams. All our strategy is work for to make different areas in the hospital that Dr. Castells says to make a protection for the patients, but of protection for the workers. And all the hospital change a lot of sites and a lot of units change. Wait a moment. The principal function of these units. How make what's implemented activities make with all the units? We make a coordination of other departments. For example, general service. General service is the responsibility to arrive all the materials that we need for protection or for to attend make for the patients. Infrastructures, information techniques in informatic techniques. The committee disseminate every day, perhaps every day, every week, different procediments. All these procediments, it's in a part of our intranet, the hospital, and all the workers go there to have the information in time, on time. Implementing activities, for example, mental health support to staff. I detected in all workers, but priority in nurses staff that there is in the first line, risk of psychological, and they need support. All the physicians, psychiatric physicians, and nurses of health, mental health make support at the other nurses that make the attention in the first line. Another activity is and very hard activity was the distribution of the materials. The coordination of social workers and physiotherapists, coordination of the sales circuit. This circuit is very important to have an exquisite order, because in the first time of the epidemic, not only in our hospital, in the other hospitals, there is some problems with the disease circuit. Here, I have an idea that our nurses, specialists in transplant coordination, make a support at the nurses staff in the units of hospitalization to make all the gestions, of the disease patients. And another thing that we work a lot was the communication strategy with the families. It's forbidden to arrive the families in the hospital during the first time in the epidemic, and the patients are sad, and the nurses with another professionals make the support with a program that says approaching distance with this program with tablets and mobiles to help to the patients and professionals and make a communications with the family. Every day we have a monitoring the occupation of the hospital by units, because the hospital changed the activity, habitual activity, and it's more difficult to make decisions if you don't have this plan of the hospital. And when we begin the desescalation, it's more necessary this planning to planificate and coordinate all the cleaning activities. Another activities that implied was the teams of training. The training you have a photography here, because we captain a lot of professionals out hospital and new professionals, and we made the continuous formation every day with the method by referent method. And recruitment of professionals, retirates, students, and new professionals. Welcoming all of these, welcoming not retirates, but the students and new professionals, we make a welcoming of new professionals, students welcoming and follow-up, and staff redistributions, because every day we have some workers that that have the COVID, and we make in every turn, at night, at afternoon, make a redistribution staff. Another, to make this distribution, we analysis all. Okay, the analysis of departments and units in which there was little or not activity recollection of excess. Identification of the professionals' skills. It's more important now all the professionals and with the skills, because we reformed all the hospitals in critical areas on semi-critical areas. These professionals that not expert in critics have a reference in the every one of unit, and review and adaptation of the nursing shifts due to the constant change, because we have a general coordinator in every turn. Adequacy, all the times we not have a lot of professionals, and we adequate of nursing patient ratios. And another things that we make is the institutional representation inside and outside, external communication, and we made research. Here in the hospital there is 200 projects of research. There's some ones of the nurses all made research, and every day we have a contact, medial contact with all my team. Some slides to make the census of all the professionals in different moments, and every day we make a congratulations at our teams, because we must to want a good team with values more intensive. They work all together, a very good team, and I would show some congratulations to them. When Dr. Castells and me explain these things, I always finish our presentations with these words: calm, caution, support, coordination, and confidence. Thank you for all.
Gemma, thank you so much for an excellent presentation. It's very clear the good teamwork that you have. All those letters, that's fantastic. And thank you very much for just highlighting how important it is to have the cadre of nurses participating in management and containment strategies. Thank you again. So we're going to be moving now with our last speaker of tonight, Dr. Tria. Dr. Tria is the head of Preventive Medicine and Epidemiology at the Hospital Clínic of Barcelona. He's also the Dean Medicine and Health Science School at the University of Barcelona. Welcome, Dr. Tria, the floor is yours.
Hi, good afternoon. I hope you are all safe and well. I will try to be as short as possible. And my main job at the hospital is working as epidemiology consultant. So I have a sort of interface between the public health, the situation in Spain or in Catalonia or in Barcelona in terms of public health, and how to apply the data and the knowledge and the different protocols that are used daily in the hospital. I will share with you the screen. So I will just be very fast about a review about the epidemiological update and the prevention of control here in Catalonia and in Spain. This is a kind of classic epidemic curve. This is the epidemic curve of the COVID-19 disease in Spain, close to 300,000 cases, close to 30,000 deaths at the time being, one of the hardest hit countries in the world in the proportion and absolute number of deaths. But now we are at the end of this curve, fortunately, by now. So instead of thousands of cases, we now have hundreds of cases, and even some days, even less than 200, 150 cases in the whole country at the present time. As I mentioned, we rank among the 10 or 15 hardest hit countries as far as to now. This is a movement scale, but as you can see, some big countries like the United States, some small countries like Belgium or Ireland, and some Nordic countries like Sweden or the United Kingdom is also in the rank together with Spain in number of cases of COVID-19 per million inhabitants. We start with a containment strategy. We believe wrongly that all cases or most of the cases should be imported ones from China, from Singapore, from Hong Kong, from Italy even, and we focus only following national guidelines and international guidelines, trying to then identify those imported cases. It does not work. The public health system cannot copy with a high number of patients that are not from imported cases, because we are pretty sure that we have already ongoing community transmission since the beginning, with a lot of asymptomatic patients that we don't know at the time they exist. First data from China states that probably between 1 or 3% of all cases could be asymptomatic ones, and now we believe, and all the data point out that should be at least 40% of the cases. Now we follow these directions. It doesn't work and we move to a mitigation strategy that I will show you, and it's probably quite similar to the one that you use in your country. We are now back to this containment strategy now, as you can see, with a lot of more capacity of testing and trying to identify the cases and try to break down the chain of contact. And this is now the main strategy in the whole country, to identify the outbreaks and try to find out as many cases as possible and to isolate the cases or to quarantine the contacts. The problem, as I mentioned, is that the number of asymptomatic cases, 40%, that's a black hole in any kind of surveillance or active surveillance that you can try. These are the invisible patient, the invisible people. They have no symptoms, they go to work, they move freely, and unless you make an extraordinary effort to find them, you will not find them, because we only much rely on the detection of symptomatic cases. So this is a very complicated to handle problem with COVID-19. Although Spain at the beginning have very few capacity of testing with PCR, now we rank among the 3 or 4 countries in the world with a lot more PCR testing per million inhabitants. In fact, in last statistics from a week from now, we rank at number 2 with more than 100,000 tests per million inhabitants. Number 1 at the time being is the United Kingdom, that certainly is a bigger country, and followed by the United States, Italy, and Germany, for example. The difference between Germany and Spain, and we do a lot of tests now at the end or when the first wave is already controlled, but Germany start doing a lot of tests since the beginning, and they don't restrict the testing for those people following exactly the international guidelines. So they try to test in a more open, in a more wide fashion, and they find out people without many symptoms and people who are from inside Germany who already have the disease, when everyone believes that the disease should come from China or from Singapore or whatever it is. in the most important phase that Dr. Castells and Dr. Martinez has already reviewed, we just devote all the resources and more resources that we ever had to treat the patient and to try to flatten the curve. As has been mentioned, and a difference to South Africa at first in the beginning is that probably the males to females distribution is pretty much the same, although males are suffering more severe cases. The second one is we started with an older age. 60 years is the mean age of the cases at the beginning and in the middle of the outbreak. But now at the end, or close to the end of the first wave of the outbreak, the age is lowering, and we are now close to a mean age of 50 years. More younger people less than 15, 20, 25 years of age are now being detected, fortunately with mild symptoms, and even most of them without symptoms, and this is reducing the average age of the patient. The symptoms, I will not go very further. It's very difficult to diagnose from a clinical point of view. There are a lot of symptoms. We believe first that most of the people should have respiratory disease. That's true for 30% of the patients, but we have patients with gastrointestinal symptoms and some patients, I'm quite sure that you've seen a lot of them, with strange disorders of taste, smell, and things like that. The ratio of patients admitted to ICU is quite low in Spain. This is the number of overall cases in Spain, 5%. And the case fatality rate is one of the highest, 8%, although if we take into account the likely number of people infected, for each case diagnosed and counted means PCR positive test, there should be between 8 and 10 more cases not diagnosed. And that means that probably the finally case fatality ratio in the overall country will be close to 1, maybe 1.5%, which certainly lower, but still very high compared to other countries. Age distribution in Spain is an older country. A lot of people is older than 70, 80 years of age. And in the colored bars, the women on the purple side, the men on the brown side, you will see that disproportionate number of cases who suffer from the most severe forms of the disease. This is a disease that is quite severe in older people, and in an age distribution certainly different from the population age distribution. The ICUs have become overwhelmed in the whole country, and as Dr. Castells and Dr. Martinez said, we have to do very, very strange things that you never believe that your hospital can do in order to make as much as ICU beds as available as possible. And we start from a point that it's also quite important to taking into account. The number of ICU beds per 100,000 inhabitants in Spain is close to 10, just compared with Germany, close to 30. That means 3 times higher, or Italy, slightly higher, or the United States, that is even higher. So we start from a point that we don't have so many ICU beds. This is one of the key points of the mitigation strategy with severe cases, to have enough ICU beds as much as possible. The death of the Spanish patient is clearly concentrated. These are the brown bars, the number of people, the percentage of people who dies up to the total of people who had died. 60-70% of all the people who die has more than 80 years of age. An additional maybe 20 something percent, it's older than 70 or to 70 to 79. That makes that if you add those two up, nearly 90 something percent of the people who die is older than 70 years of age in Spain. The good news is that the lower the age, the younger the age, the lower the number of people who is already in ICUs or who's already having severe forms or die of the disease. Just a few words for the healthcare workers. Our unit works very closely together with the healthcare workers prevention unit. And in Spain, this is one of the most striking features of the outbreak. We have 25% of all COVID-19 cases are cases in healthcare workers. That's a quarter of all cases are those who to be attributed to the healthcare work. That means close to 40,000 of healthcare workers infected up to date. Fortunately, only 10% of them had been admitted in the hospital, and even more fortunately, less than 1.1% were admitted in the ICU. notwithstanding, we have to mourn more than 70 deaths among nurses, doctors, and all the healthcare professionals up to now in the country. And I believe, fortunately, not in our hospital, although we have some days that we are just praying that the morning after we will have enough PPI for everyone. In most or in some hospitals around the country, there has been a lot of days with shortage of PPIs, notably in the long-term care facilities. Long-term care facilities is another very terrible aspect of this outbreak. A lot of people infected, a lot of people dying, and this is not a healthcare facility, so people is not prepared to handle this high number of cases in long-term care. But the photograph shows a situation who has been a matter of control of problems and a political issue. There is not enough PPI during the most hard days of the epidemic for all the healthcare workers. We go through a very stringent lockdown just a few weeks after the epidemic starts. This is an image of one of the main streets in Barcelona, the Ramblas, who goes straight forward to the sea. Usually this street is full of people, and it was very devastating for us to see that no one, except very few people, is working or walking, or just everything is closed. You have to stay at home for at least a couple of weeks without many things that you cannot do during the hard part of the lockdown. A modeling study from the Imperial College in London said that at least this is probably the more effective measure that we can just choose. Without a vaccine, without effective treatments, just the protection measure and the lockdowns. And using this modeling that came out from the Imperial College in London, it said that in Spain, we probably avoid close to 500,000 deaths just by the lockdown. In some countries like France, even close to 700,000 deaths. So it works. And in the model, it supposes that we have been able to avoid a lot of people at a high cost, notably for the economy, of course, but at least the main aim was to save lives, and I think that the lockdown has been successful in doing so. A very interesting thing that I shared also with Dr. Smuts before the beginning of the webinar, and this is a very different epidemic depending on where you live. The more populated, the more movement there is in a town or in a country like Johannesburg, Cape Town, Pretoria, Barcelona, Madrid, London, New York, a lot of people who are more prone to be infected. This is a seroprevalence survey of the country, a sample, representative sample of more than 60,000 Spanish citizens. And you see that after the first wave, the central part of the country, that means Madrid mainly, and the area surrounding Madrid, has prevalence rates of 10, 12, 14%. Barcelona, who is close to the second one, is below 7%. But there are some parts of the country, either in the north, either in the south, and certainly in the islands, that have prevalence surveys of less than 2, and even one close to 1. So the situation in the country could be very, very, very different. For example, here in Catalonia, where we live, in Barcelona, 7%, few miles south, less than 2%. So people have very different pictures how the epidemic affects them. Madrid and Barcelona, the hardest parts of the country hit by the outbreak. But still, living in New York, in London, in Madrid, in Wuhan, where everything starts, in Boston, in Stockholm, or in Barcelona, the prevalence surveys said that maybe less than 20% in the best of the cases, and mostly less than 10% of the people, at least measured by the antibodies response, is infected and should be considered to be immune. We believe that herd immunity will be something closer to 60%. So a bridge too far to rely in herd immunity to control, at least in the next years, this kind of outbreak. And I will finish with this photograph. This photograph was taken in another hospital in Barcelona. I think that it's easily understanding. In Spanish, it's called Hospital del Mar, that means sea hospital, because it's just a street away from the sea. This is the Mediterranean Sea. And these are nurses and doctors from the intensive care unit of the Hospital del Mar that at the end of the outbreak decided to take a patient who's already been for a couple of months in the ICU, fortunately, supposedly recovering well, just to cross the street and put them in sunlight and see the sun. We all are very relieved to see these images. That means things seems to be a little bit more under control. But we cannot be caught off guard another time. We have outbreaks now, localized outbreaks, some of them of 100 cases, some of them of 1 dozen cases, 10 cases. So we should be very, very, very aware of how the epidemic unfolds in the summertime here in Spain. As a main conclusions, I think that we don't have many other instruments that apply all the prevention and isolation measures. We said distance, hand hygiene, and face mask, the 3 basic things. Very much important to try to protect as much as possible the healthcare workers. They are the first responders. We have to give confidence of them. They are exposed to high loads of virus in hospitals full of patients with this kind of virus, so we should protect them. We should rely again in the basic measures again, and also in population terms, the hard measures are the social distancing. Stay at home when needed, and even restricted movements and certainly gatherings, especially in closed places, not in the open air, but certainly in closed spaces. I finally will end with a famous sentence from Peter Medawar, who has been awarded the Nobel laureate in medicine back in the 60s. And I think it truly reflects what we are facing. A virus, is always a problem wrapped in protein. Thank you very much for your attention, and I'm happy to take the questions at the end. Thank you very much.
Thank you so much, Dr. Trilla, for the excellent presentation and the comprehensive epic profile of the COVID pandemic and the presentation in Spain. And also, I have to say that Spain is a blessed country who can provide our patients with that amazing view, even being in ICU. So with this said, we're going to be moving quickly to the questions. I'm receiving here questions from our IT team. I think that we're going to start with the first speaker, with Dr. Castells. Dr. Castells, I would like just to summarize a couple of questions that have been asked by our attendants. One of them is they are curious to know how the COVID-19 has changed any processes in the hospital for the better. And this is linked also to this question that what did hospital leadership did to manage a tangible impact at hospital level? Maybe we can start with those and then we can move to the triage if we have the time. Thank you, Dr. Castel. The floor is yours.
Okay, thank you, Maria. Thank you for the question that the person that have done. Well, I think that COVID pandemic changed a lot our clinical practice in many ways. Probably if you want to refer a very practical one, I would mention about telemedicine. That telemedicine, I don't know in South Africa, but here in Spain was a dream, let me say. I mean that we tried to implement telemedicine in many ways, but was difficult because they need some technical requirements. You need to convince people that they can use different devices, the cellular phone or the computer to communicate with the hospital. But the COVID changed this perspective. I mean that everyone understood that that it was at when the epidemic reached the peak, was better to keep away from the hospital and just to continue in contact with the patients with chronic diseases. Telemedicine, I mean the video conference or teleconference, was very useful. And at that moment that we are at the last part of the cure, as mentioned Dr. Trilla, and we are attending our patient in a presential manner in the hospital, we consider that it's better to continue using telemedicine for some patients. I mean, at that moment, we want to keep the distance between them. I mean that we don't want to concentrate them in our waiting rooms. And that is a way that combining presential visit with telemedicine is a way to keep this distance, but at the same time, we're avoiding patients coming to the hospital just to see, for example, the result of a test. I mean that people has to come to the hospital to be explored, but to comment on the results sometimes is enough to have a teleconference. I mean that for me, telemedicine is one of the lectures of this COVID, one of the positive lectures of this pandemic, and I think that we will continue using it after the COVID pandemic. Probably there is another lesson learned in this period of time that that is not a practical one, but is a more conceptual, is that during these last 3-4 months, I think that the specialties disappear from the hospital. I mean that every physician work in a similar manner. I mean that all of us are attending the similar kind of patients. I mean that even though this is a university hospital, that there are several departments, and each of us, for example, I am gastroenterologist, and I am defending the gastroenterology department. This situation, this so fragmented hospital has changed a lot. I mean that at the moment, I think that all of us are a little bit more polyvalent than we used to be before.
Thank you so much, Dr. Castells. We're going to be moving now to Mrs. Gemma Martinez, and we have here a couple of very good questions for you, Gemma. So one of them is, good afternoon, what worked well to improve and maintain the staff morale? And this is linked to this one, so I'm going to read the other one too, because they are linked. So how did you ensure that if nurses were reallocated to new areas, they were able to handle the COVID patients without being scared or anxious?
Yes, well, I show you some pictures and with a lot of images, because it's the more difficult thing. I think that we have very good professionals, very good workers with a high level resilience in work. And all of the team make professionals with at the coordination team, because they want to help at the other worker. Do you understand? All the workers make help at the other workers. We make an apple and a good team and a very hard team. How we maintain the morale of the team? Be by his side, stay all the day and perhaps a lot of nights in the hospital, and speak information, a very good information. It's very important, the communication in all the hospital. Only one place on to make the information. All we speak in the same form, and we make all the procediments in the equal form, because it's more important all work all together and in equal form. It's more important. And stay by his side. I say, yeah. Every day I make a mail that I show you one with congratulations, because in every unit, in night or in afternoon, there is a notice, a notice for to make that this notice elevate the morale of the workers, and all the workers change the congratulations ones for the other ones. And in the people that have some problems, I say you after that we have a support of psychologists and nursing, mental nursing, that make a support of the other workers with some techniques of relaxation and distraction of the different forms. But stay behind all of the workers. I say this one.
With the connection.
I don't know, I make anything.
Would you work hard enough? And I don't know, you want to add a last comment right now?
No, I say that the most important is the communication and stay aside the workers all the time, with the telephone, with the mail, with all the things that you can think, because they have a lot of duties, but it's not important. Stay there and work all together. We learn a lot of things with this epidemic, but the more important thing that all the team work together. It's the more important. And one is the referent of the another one, and in some moment, and in another moment, it's al revés, behind. Okay, it's not, and the people, it's very good professionals, but in the final of the curve of the epidemic, we are tired. It's more important the recuperation post-epidemic, because all of us are tired and we want to make a holidays.
So that's excellent. Thank you. And cohesion. So thanks a lot. We're going to be moving now to Dr. Trilla. Dr. Trilla, we're going to be asking you a difficult question. And this is related to the triage. So the question is, how did doctors make triage decisions on which patients to put in the ICU or ventilations, or to de-escalate care? Sorry, this is a difficult one. And also this is linked to another questions. Were specific software solutions developed to support the management of the patients in ICU triage for ICU admissions? I don't know if you have any software that could be used for this decision-making. Thank you.
Thanks for the question. Certainly the triage one has been an issue throughout the pandemic, especially in the days that the ICUs are close to be overloaded. But at least I have to say with enough proud of our profession that we follow the guidelines from the ethics committee of the hospital. These are guidelines that are commonly used in a day-to-day decision of taking into account the survival probability, the age, the quality of life, the life expectancy, and many things that are used on a daily basis in the hospital to admit a patient with, I don't know, cancer, widespread cancer or a chronic disease to an ICU or not. And the only difference is that we have to do a lot of decisions every day. So we have to be very careful of doing these decisions as much as possible, following strictly those guidelines. And in case of doubt, there is a continuous support of the ethics committee in order to ask a difficult question. And certainly another thing that is commonly used over the outbreak is in case of doubt, the decision is made by none of the attending physicians. So it is an outside physician, also a specialist, who is not directly responsible of the patient. If there is any doubt, there is a sort of a referee that adheres to the guidelines of the committee and puts up front the best possible decision, as much as possible discuss with the family, which is not an easy thing because of problem communication. Sometimes we have to talk by phone and things like that. But as far as I understand, I think that ethically, the more difficult part of the epidemic has been handled quite well in Barcelona, in Catalonia, in our hospital. Maybe in other parts of the country is not so clear, or there is some confounding information. But at least, although we have to make very tough decisions, I think that I've made as much as possible following the guidelines of an independent ethics committee and in case of doubt, of an independent physician. No? The second one about the triage protocols, I think that we have triage protocols and scores and things like that. I don't know if this is already implemented in a software solution. There is a lot of people working now in handling big data of the cases that we have handled during the epidemic, and certainly there are some models trying to identify diagnosis procedures, sensibility, specificity of the test, criteria for admitted, survival probabilities. We will probably end up having enough software, but at the time being and during the epidemic, as far as I know, I don't know if Dr. Castells is aware of different things. We use different algorithms and protocols, but not, as far as I understand, implemented in the IPP or in a software product.
Thank you so much, Dr. Trilla, for this very comprehensive response. With your permission, I would like to make a change. And instead of responding to questions, I would like to give the opportunity to Dr. Smuts, since he hears such a gifted panelists, speakers, and providing us with such an important recommendations from their experience in the pandemic. I would like to give you the opportunity, Dr. Smuts, if you want to ask any specific questions that you think that will be relevant for the context in South Africa.
Thank you, Maria. I appreciate it. I think my colleagues have actually asked very practical questions. Maybe I would like to ask a question of continued engagement after this webcast, that maybe via email or electronic communication, we can forward some of our questions to you. And within your healthcare community, you can actually ask your colleagues for some input and then revert back to us with the answers or advice or guidance that you can actually obtain from your colleagues. So I think there's a general process question from my side. From a specific question, I think my colleagues actually have asked them. So thank you very much.
Thank you so much, Dr. Smith. Definitely we'll revert to you with some of the recommendations, but also would like to open the floor to all the speakers. If some of them had any specific comment that they would like to provide at this moment.
I think that it's very important to share experience. Experience could be very different from country to country. The health system could be different, the age distribution, I don't know, even the virus could be slightly different. We don't know. But at the time being, I think that we learn a lot. We learn things that we finally prove wrong. For example, in the side of the treatment, we are still a little bit confused about which treatment really works and which treatment doesn't work as well as we believe at the beginning, with very anecdotal data. But as soon as clinical trials are being published, we start knowing that some of the things that we have used at the beginning of the epidemic, we probably had no very much benefit for the patients. That's one thing. A lot of information going very fast, and it's difficult to handle, difficult to understand, and difficult to analyze. Also, as for my point of view, I believe that in South Africa, the situation could be different, but the epidemiological data quality are not very good over the pandemic. The public health system has become overloaded, and most of the time we have to navigate, to sail to an uncharted territory. So we don't know exactly what's going on. So this is an important thing, to have reliable information. And I would like also to add that it's an extraordinary experience, a hard one for any one of us who had worked very much together on a daily basis. Dr. Castells, Gemma, and other colleagues from the hospital meet every day at 8 in the morning, that we call the crisis committee, and we try to understand what's going on, which decisions have to make. I would like to thank both of them for their leadership and guidance, and certainly for a thing that I believe that Dr. Castells has stressed, what I would like to emphasize again. We make many mistakes, but we have been able to try to correct the mistakes as soon as we make it. So we were far from perfect, but we rely very much on the experience of the frontline workers. Sometimes are the natural leaders, sometimes as people that we don't know at the time being. We have not identified them, but they had been able to solve most of the day-to-day problems that have to be solved on the bedside, on the organization side, and making, I think, very good decisions that direction of the hospital supports and give them, let's say, all the support to implement them. So it has been really a teamwork, and this is one of the things that I think all of us has very proud of. Not certainly not only in our hospital, in every other hospital and every other primary care center in Spain. I think it's a general feeling that we have working very closely together, and this is a good thing to be reminded, because there are other things that we forget very easily. For example, the distance, the hand washing, and the face mask is relaxing very much here in Spain. There's a lot of sun, a lot of hot, and we don't know that if the infection rate will increase in the near future, but that's life. So we have to live with the virus and try to copy with them the best that we can. Good luck to all the South African people, and I think it's an all English saying. They say, I wish you, or we wish you, Godspeed.
Thank you for the good wishes, Dr. Trilla. Dr. Castells, any other word of wisdom before we close?
Thank you, Maria. No, I fully agree with Dr. Trilla that I think that when we start facing this crisis some months ago, we have three difficulties. One, that we didn't know about the natural history about this disease, and even at that moment, we don't know everything about the COVID-19. The second was the problem about the shortage of material. That was a real nightmare at the beginning of the crisis. And third, but I think it's important, that we don't have guidelines, we don't have evidence-based solutions, and that, as mentioned Dr. Trilla, we made a lot of errors and mistakes, and we try to amend them. And I think that to correct these difficulties, I think is very important. The thing that we are doing today is to share the experience, because I think that the problems are very similar all over the world. And then, as Dr. Smuts mentioned, if you have other questions that we want to address us, it will be a pleasure to try to answer as fast as we can. Thank you very much, and good luck.
Okay.
Thank you. Gemma, you want
Yes,
to say something?
I only say 5 words that I put in my pictures. Calm, serenity, calm, caution, protect, mask, hand wash, that said Dr. Trilla. Support, stay at side of all workers, stay all the day, all the night. It's very important, the middle coordinations, the middle boss of the different levels. Coordinations, all the team, physicians, nursing, and other professionals. Confidence, and good luck. I say good luck.
Okay, well, thank you so much for this excellent presentation, all of you. The panelists have been absolutely fantastic. We're coming out to our time allotted for this webinar, and I would like just to follow up with what we said at the beginning, that, and I apologize on regard of the organization committee, we're not being able to answer all the questions. They're fantastic questions that you guys have been asking, but all the speakers are in agreement to review those questions and provide you with responses that will be posted in the web page, in the YouTube page. Some of the attendants have been asking for the presentations. The speakers kindly agree to share their presentations. So there is a way in which you can access those presentations, and it's through, again, the Slido link. So please go there to the Slido web link and insert the code as hashtag COVID-19 South Africa. I think that this is going to let you to a small satisfaction questionnaire that will help us just to understand what is the things that went well and those things that we have to improve, and that will support